But I don't know that I'm going to do that yet. I think I'm going to get through this process recording and then let you guys go.
Over the moon.
All right, so our process report, because I want everybody to understand that this is not supposed to be all therapeutic. Okay? So, excuse me, what happens is, and this is on my slide, so I'm not going to go one step by step by step. When you develop a relationship with someone, the first thing you do is introduce yourself. Okay? Now, that is like the introductory part of this relationship, or this assignment, your introduction. I need to see that you're going to introduce them, and I want to see how you're going to start. That this is what your plan is, to have a conversation with someone. Okay? So I want to see how you're, I'm not going to stand here and say it needs to say this, 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 and this. I want to see how you start a goal-oriented conversation with your patient, with your person. Question?
Is this, where in our slides will this be? Is it the health relationship?
Health relationship.
Okay.
Health relationship is telling you how you develop and what should be included in this goal-oriented conversation. Okay? Health relationship. So, I went in, I've introduced myself, I've actually put that I shook my patient's hand, that I stood at the side of the bed, okay? And some of your nonverbal communication will actually be, I slid a chair up and sat down, okay? Those kind of things. Touch, like let's say you want to just touch someone, that's included in your nonverbal communication. So what's going to happen is you're going to have a statement that you said right here, along with your nonverbal communication. Then you're going to come to this column right here, and it says, was your response therapeutic or non-therapeutic? So you look back at this statement right here, and you say therapeutic. Okay? What type of communication? Where are you going to go to get that information?
The table.
Your table. So this was a therapeutic communication. I'm going to go to pages 472 and 473, and I'm going to figure out what type of communication did I just say. Giving information is one. Using silence is one. Okay, that was therapeutic. Paraphrasing. Stereotyping. So if it was stereotyping, what would I have up here first? Non-therapeutic. So if I stereotype in my statement, I'm going to put non-therapeutic, stereotyping, and when I have a non-therapeutic statement, I need to restate it so it will be therapeutic. In other words, if I say something that ain't right, okay, I need to look at another way I could have said that to have gotten more information out of my patient, to have made it a therapeutic statement. Does that make sense? Now, if you have a therapeutic, like my statement right here was therapeutic, do I need to restate it?
No.
No, you do not. Because you had a therapeutic statement. Okay?
And on Harper's, want to see us feel both it's okay to say something we totally know, just so we can have something, like we said, like 4-year-old or shop as well versus school. We can do that knowing that we're really not, we'll never do that.
Exactly, because the ideal of this assignment is to see how you communicate with somebody, and am I really talking right? Am I communicating right? Because a lot of times when you say a statement and you get a response from the patient, like a yes or no, or I don't know kind of thing, is that information going to help you take care of that patient? So now I'm going to have to say, okay, whatever I just asked them, I didn't get the information I needed. So I need to say it again or say it another way to see if I can get some more information out of my patient. Because I really want to know, how do you feel about being in nursing school?
So would you write that was non-therapeutic because you didn't get what you needed and then restate it?
No, it's not always it might, depends on the statement. If the statement is non-therapeutic, then restate it. But if you said a therapeutic statement, then you say therapeutic. But you know that you're going to keep on digging. Okay? Because I ain't getting no information from this patient. And I can't make a thorough investigation or a thorough assessment of this patient to help me meet that goal if I don't get more information. It's just going to give you an opportunity to look and say, how do I really talk to people? How do I really communicate with people? And I want you to look at how you do talk. I mean, some of y'all's conversations that you have with me, I'm thinking, okay, we need a little work on this communication skills. And that's what we want to do now. We want to look at, I've got to teach you how to be therapeutic and how to be professional. Okay? Okay. Do I care what not that I don't care. My patient's going to say a comment to me, right? And they're going to be saying, do I need to evaluate their comments? Because they ain't worried about being therapeutic, are they? My patient doesn't have to be therapeutic. I have to be therapeutic. So some people like to go and evaluate my client and what they made, what conversation they made, or a statement they made. I don't want to worry about them, what they've got to say. I want to look at you. I want to look at how you handle the situation. Your classmate may want to give you some information to help you learn, or to help you learn, but to not give them a lot of answers. Not give them. Be very short with them. Make that person that's communicating with you work for making sure that they get the information. Okay? Now this, go ahead. Because closed-ended questions are considered non-therapeutic. So you've got to restate that closed-ended question to make this open. But I'd love to see you follow up, because there's a lot of times you're going to have to follow up with an open-ended question after a closed-ended question. That's where I don't know. Sometimes I had to say a closed-ended question is not therapeutic, because there's so many times it is therapeutic. But what State Board of Nursing says, and that's what I want to make sure that I teach you, is that closed-ended questions are non-therapeutic. Does that make sense? Even though we use them to gather information. Because there's some questions you have to ask the patient, and you have to get yes or no. Are you constipated? Yes. Do you have diarrhea? Yes. I have to know those. I mean, that's just. I mean, most patients are not going to say to me, when I say, do you have diarrhea? Yes, I have had 4 stools in the last 24 minutes, and they are dark and brown, and there's a little bit, when I'm white, there's a little bit of blood on the toilet paper. See how much information I just gave you? There's a lot of patients is not going to give us information like that. But that was vital information because I need to know that my patient gets to the bathroom 4 times. And it was brown and it was running. And he had a little blood on his toilet paper. That's good. It would be lots of information. But most patients, when you say it, you have diarrhea, they're going to say no. And then you got to back it up with, or if they say yes. So, well, tell me about how often have you used it? What does it look like? Comparing blood. That would be just more questions. Because I need to know how to get the most information out of my patient to help me make a wonderful assessment on my patient. Okay? I got to get lots of knowledge. Do you have a question? Or are you just wiping your nose?
Oh, I'm scratching my eye.
Scratch. All right. So, during this introduction phase, and here's your first conversation or your first statement, nonverbal, and then you put what the patient said, and then you address if it's therapeutic, non-therapeutic, and the type of communication it is. Restate if it's non-therapeutic, and then you go to the next one. Okay, and the next conversation. Now remember, you're not talking for 30 minutes. I don't want to hear or have to read a 30-minute conversation with y'all. Okay? I don't want to do that. If I had lots of time, I would do that. Enough time to read 30 conversations. Now, I told you the first day when we started talking about I was going to tell you I'm talking about critical thinking. I can't tell you how to critical think. I can't teach you how to critically think. I can give you techniques to help you critically think, and I'm hoping that that's where we're headed right now, to teach you ways to critically think. Just like yesterday, as you were doing your process recording, you were having to critically think how I could communicate with this patient to get as much information as I needed. What does it mean to critically think? It all boils down to making sure that I get a goal for my patient and help them meet that goal. It is a combination of information all at one time. So in other words, I can't just say, I'm going to use this skill to help me critically think. I've got to have a whole combination. And we're going to talk about gathering that information to help me make some critically thoughtful decisions when it comes to meeting my goal for my patient. Things to make sure that you include when you are critically thinking, and you will hear me say this 5,000 times, and you're like, Ms. Walker, quit telling me this. I have to make sure in my practice that whatever I do, I'm keeping my patient safe. That is the number one thing. I have got to make sure that I'm keeping them safe. When I'm talking about safe-wise, let's say we're getting ready to go into a patient's room, or you're the nurse, okay? And you've got an order that says go put a catheter in. Do you know how to put a catheter in? Well, maybe some of you that are CRNA2s or CNA2s. But let's say you don't know how to do it. And you go right into that patient's room and you start to put that catheter in. Are you being safe? No, you are not being safe. You are jeopardizing the safety of that patient, and that is not going to happen. Okay, because you have not been taught correctly how to do that. Another example, and I think I did this to some of you guys in the hospital, in the checkoff thing, I think I really did enjoy. When he walked into the patient's room, the bed was in high position and the side rows were down. Did you even think when you walked in there that was a safety issue? Joy, did you?
Well, I didn't initially, but
Right.
I did realize it.
Yeah, but
Patient fall out of bed.
right. So I'm that's a simple critical thinking skill. So in other words, when you walk into that room, I expect you to be looking at that. I expect you to make sure that when you go into that environment that your patient is safe. Now, I was tricking y'all. I mean, I don't usually try to trick you, but I was trying to do it in a way that it would come as a natural thing to you. That as you go take care of that patient, you are focused on the safety of that patient. Now, I will tell you that a couple of years ago, we had a PN student that, and I know y'all probably already heard about this, but she was in a nursing home. The patient's bed was in high position. The side rails were down. The patient said, "Oh, I'm fine. I can do this by myself." 90-year-old lady fell out of bed, broke her hip. Okay? See why I have to tell you. You have to, and when you go into a patient's room, you're not saying, "Oh yes, I am critically thinking. I have to keep my patient's bed in low position and the side rails up." You see, that you're not thinking I'm critically thinking, but you are critically thinking. Because it's all about keeping that patient safe. Okay, so the skills you got to know. Is this something you're going to learn just like that? No, it's not as far as nursing. And you're going to be frustrated. You're going to cry. You're going to, when you make a mistake. Just like I was telling somebody the other day, I would much rather you make a mistake in here in this lab with me than in a hospital setting. Make the mistakes here. Make them. Because that is going to assist you in your critical thinking skills. Okay? There's going to be lots and lots of times that you have to make decisions very quickly as your patient's status is deteriorating. They're getting worse. There's going to be times that you have to think on your feet. And I tell students every year, there are so many times that you're going to go with your gut. You're going to go with you're going to develop those skills that something inside of your gut saying, "I need to do this." For instance, when I had, and I know you probably don't know this yet, but if I had a patient who had O2 sats, you know what it means to do O2 sats? Do you know the normal range for O2 sats? What do we want somebody to be on? 100%, don't we? So you go walking into the patient's room and their O2 sats are 76. Are you going to sit there and say, "Okay, I need to critically think if my patient has O2 sats, that means that they're not getting enough oxygen to their brain, so I probably need to get some oxygen on there." Okay? Are you going to do that?
No.
It's just going to go. But you're really thinking that in your mind, right? And you just got to do it. So as you learn how to critically think, you're going to learn how to react to what's happening with your patient. There are many times, just like I said, you've got to adapt the things that you do to whatever situation is happening. And I think one of the biggest fears of nursing students is, if my patient does make a turn for the worse, will I know what to do? Is that a big fear?
Yeah.
That's a big fear, isn't it? Let's say you go into your patient's room and they are deteriorating and you don't know what to do. What are you going to do? Miss Walker! Let me tell you something. If you go into a patient's room and something's happening that you're not sure of what's going on, God gave you a mouth. And there's a lot of times you can be very loud. This is one time to be loud. Okay? I need help in room 212. I need somebody to come in there. If you don't know what's going on, hit the call bell, scream out. Okay? Because what am I doing for that patient?
Keeping the patient safe.
I don't know what's going on. I don't know what. I will tell you, I had this one patient when I was in nursing school, a baby. And I went in and I was doing my assessment, like y'all do. You just have a little baby there and I'm really doing good. And so one of the first things I looked at was the color. Because that's what the thing, go to my little checklist. I need to go through looking at the color. And I thought, well, my instructor told me I should be pink. This baby's not pink. This baby's about this color right here. It's gray. And I was like, oh, geez. Oh, geez. Oh, Lord. Oh, what do I do? I didn't know what to do. And so I'm over here going, excuse me. somebody needs to come over here. And he was making, or she was making this funky sound like, and I'm thinking, okay, respirations. That doesn't sound like that. Okay, I'm thinking, okay, what in the heck? Okay, so then I'm really going, okay, you know, somebody come over here. Well, when everybody got over there, they whipped that baby up and they took it over to this thing, and the next thing I knew, they're taking it down to NICU and all this kind of stuff. I was like, I promise I didn't do a thing. You know, all I did was try to assess this baby. I didn't know what was going on, you know, with the baby. And literally, I was having to scream out because I didn't know what in the heck was going on. Lo and behold, this baby didn't have a septum in his heart, in her heart. So all the blood was just mushing together. The bad thing about the whole situation was that baby was 24 hours old. Why did a nursing student in an assessment find something that wasn't right on a baby that was 24 hours old? Now, I didn't know what in the heck to do about it, but I knew it wasn't right. And that's what I want you to do. When you see something that's not right, you know, and I may go in there and it not be a thing. It be okay. But the fact of the matter is when you did that, find that information is you went. That's critically thinking. Because you know that you're not prepared, you're not ready to do this, you need to get some help. Okay? So those are the kinds of things that I'm going to help you do as you're in nursing school. And that's what I just said. Critical thinking skills helps you make accurate and appropriate clinical decisions regarding your client's care. I can't say that enough. I also need you to know that not always as we're taking care of our patient, it's just not me being the nurse. I've got to depend on other people to help me. The physician. Who else would you think of when we're taking care of this patient that, let's say we had a patient who was deficit in nutrition?
Dietitian.
I need to be contacting that dietitian. Okay? So that's a critical thinking skill because I know that, you know, yeah, I can give them the basics on nutrition, but wouldn't it be better if I had someone who was specialized in that area to assist me in giving them more information? Nutrition is my weakest point. I am so bad at nutrition. I know that. I've always been bad at nutrition. You can tell by looking at me. I'm bad at nutrition. Oh, that cover already. So I always have to depend on someone else. And that's a part of my critical thinking skills is that when I get to a point that I'm not sure I can give adequate information, I go to someone else to help. So I have to gather lots of information and use lots of different resources out there for me. These are some of just the techniques of critical thinking. Critical analysis. Critical analysis is just a set of questions. And I know you're probably saying, I'm tired of Ms. Walker talking about questions. But that is going to help me analyze the information that I have. Through the questions that we've learned how to ask yesterday and we're learning about, it's going to help me make that decision on what I need to do to take care of that patient. Socratic questioning, that looks beneath the surface. You got to look for different ways to do things, and we're going to talk more about that in just a little bit. We're going to talk about me doing something this way and you doing something another way and still accomplishing the same goal. Inductive reasoning is just facts and what you observed. Deductive reasoning is general to specific. When you are doing all of this critical thinking or all of these different techniques, you're not just doing one at a time. You're doing them as you are gathering your data. You're not going to sit there and say, okay, I'm doing inductive reasoning as I'm asking my patient, are you having trouble breathing? I'm not thinking like that. But just to let you know that you have to include inductive and deductive reasoning to help gather data to help you make that decision on how you need to care for that patient. Okay? Questions? No? Like, what are you talking about this one?
Could you better define deductive reasoning?
Deductive is more going to be like when you go and look at the skin. Okay? The general look of it is just the pink color and the texture. Then I get to an area that is broken down. Let's say they've got a wound. Then I'm going to have to further be better specific with that wound. In other words, am I going to have to look that it's red? Am I going to have to look at, is there any fever in there? How long is it? How deep is it? And you're going to learn more about doing wounds. But a general thing is just, I can look at you, but when I get to a problem, I've got to be very specific. Does that make sense? In other words, when you listen to the breath sound, I'll give you another example. When you listen to the breath sounds, you go in here and you hear normal, 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 normal. And then you get down here and you hear something. And you're listening and you think, that's wheezy. Okay, does it mean? And then I've got to define where that wheezing is. So I have to be very specific to what if I find a deficit. Does that make a little bit more better sense? I'm trying to see if I can think of some more examples or. You give me an example. How about that?
Inductive, like you were saying, would be just the fact that you're doing the skin assessment, and deductive would be seeing an abnormality and getting more specific on what exactly the abnormality is.
Exactly. Exactly. And I think we've talked to you about being simple to complex. Okay? Simple to complex. So you've got to, in other words, anything that you start off, and I think it's like, it is like a system. So in other words, and you did this with your communication yesterday, you may start out with a closed-ended question and say, Chelsea, do you have pain? What would that be? Inductive or deductive? Inductive. And I'll say, tell me more about your pain.
Now you're deductive.
Now I'm getting deductive. So I'm getting more specific. So when a patient tells me they've got something going on, then I have to keep digging. Tell me about your pain. Well, it's radiating down my arm. I hurt up in my chest. So that's giving me what? My questioning is giving me more information. So as I need to call the physician, as I need to do an intervention, which we'll talk more about, I have lots of information that I know I'm doing the right thing for that patient. Okay? Is that, I think people might have got that. I think so many times what you're used to is your other classes that you've had, and it is what it is, what it is. Nursing is not. I wish I could say every patient that comes in with chest pain, this is exactly what you're going to do. I can't do that. I have to learn how to think out of the box. Let's say Chelsea did come in with chest pain. And I was able to do, let's say I gave her nitroglycerin 1 pill under her tongue. And guess what? Her pain's gone. But when Hope comes in, she tells me she's got chest pain. And it's radiating down. Same thing. They're telling me the same symptoms. Chest pain, radiating down the arm. Feels like an elephant's on my chest. You told me that. I gave you 1 nitroglycerin your pain's gone. Hope comes in, that one nitroglycerin didn't help at all. So I'm just going to say, Hope, you're okay, bye.
No.
Because Chelsea did that. It fixed Chelsea, didn't it?
Yeah.
But it didn't fix Hope. So that means I got to do more. I got to do other interventions. I got to do other things because everybody is different. Everybody's going to respond different. Give me a Benadryl, I'm out for 3 days. Okay? Give Angela a Benadryl, and she is wired, and she is climbing up in the light fixtures. Okay? Everybody does different. That's where you've got to critically think in everything that you are doing for that patient. How are they responding? And we'll talk much more about that. Think for yourself. And you're probably thinking, oh my goodness, I can't think. Because I don't know what's going on. But believe you me, you will be able to handle more situations than you realize. Okay? When you get into the actual setting and you're doing this. You've got to start thinking, and you know what I'm going to be doing and your clinical instructors are doing? You're going to come to me with a problem. Miss Walker, I can't, my patient's got something going on in his lungs. Okay, tell me what you hear. Well, sometimes it sort of sounds like a little squeaking. So, okay, if a breath sound was squeaky in there, what breath sounds would that be? Did I tell you any information? I made you figure it out. That's exactly what we're going to do in clinical. I want you to figure out, because you know what, the next time you hear that crackling sound in there or whatever, you're going to say, I heard wheezing. Okay? That's going to help you in building your critical thinking. The other thing that you want to do with critical thinking, and I think a lot of you do this if you're a CNA, and you think, oh my goodness, I saw that nurse do it this way. But in class, they told me to do it this way. Oh, that nurse is wrong. Is that necessarily true? No. No. You have to be open to trying to figure out different ways of doing the same thing. Same thing with that assessment. We gave you a printout, and a lot of you came in and just vomited that thing right back at me. Right? Okay? But if I would have said, oh goodness, that's not the way I do. You didn't do it the same order as I do my assessments. So that means you're wrong. No, it doesn't. It means you've got to figure out what works for you to make sure that you get all the information you can and look at keeping the patient safe. I know that we've talked about saying, I don't know. And that's okay. It's on this PowerPoint, so if it's on this PowerPoint, it is just like the Bible. Right? It's okay to say I don't know something. When you start acting like you know everything, that's when you're going to have a problem. The other thing that will assist you in critical thinking is don't stop till you find the answer. Don't stop. Because you're going to have to, there's going to be lots and lots of times that you don't know what is going on. And you've got to figure it out. Every day I learn something new as far as nursing. Every day. And you've got to continue to gather more information, and as you gather more information, see other people do things, work on your skills, that is going to foster your critical thinking skills. Okay? It's going to assist you. Don't ever be afraid to ask questions. I think all of us that teach in here have an environment that you feel comfortable in saying, I've got a question. Please do that. You may think it's the stupidest question in the world. I have called more doctors and said, I will tell you this one. Well, I can tell you that story yet. I've called many doctors and said, I don't know what I'm seeing, feeling. I don't know. you know, after I went and got another nurse or whatever, got somebody else, you know, help me, I've called more doctors and said, look, this is what I've assessed, this is what I've, but this is going on and I don't know what it is. And when you are able to do that, then that is going to assist you in your critical thinking skills, but it's also going to gain respect from those physicians to say, you know what, she didn't know the answer and she didn't stop until she found the answer. And that's going to gain a lot of respect from those physicians. Any questions? Problem solving. When we are getting ready to go learn about the nursing process, you're going to have to use critical thinking skills to assess or to figure out what do I need to do. Okay, as far as your assessment, and I'll talk more about the nursing process, but really what's happening when we do an assessment and a patient comes in is they have a problem. My job as a nurse is to use my critical thinking skills to assist me through the nursing process to figure out how can I fix it. How can I fix it? It's the same thing when you guys make any decision about anything in life. For instance, when you decided to come into nursing school, was there a lot of decisions making going on? Yeah. Am I really going to make this decision? The nursing process is the same way. It is the same way that you have. That wasn't necessarily a problem. It was a goal that you had set for yourself, and you had to make a decision by gathering data, like what classes do I need? What tests do I need to take to get into the thing? You gathered all that data to help you make that decision on how do I reach this goal. That is the same thing we're doing with the nursing process. You use critical thinking skills to assist that. The other thing that I want you to realize is when we are doing this, we have to make sure that what we're doing is effective. Get what I'm saying? How many people had little roadblocks as they came in to the nursing program? Oh my goodness, my English is 12 years old. So, what did you do?
Took it again.
You had to take English 111 again, right? It's the same thing that we're doing with the nursing process is how we made those decisions. Trial and error. I've talked about trial and error as far as you doing your assessments, right? I'm going to try it this way. Guess what? You're going to do skills. You're going to see us do the skills, and we're going to demonstrate the skills to you. And then you're going to get all the information, all the equipment and everything, and you're going to look at it and go, okay, I really don't like that there. If I moved it over here, I think I could do the process of this skill better. Well, you do it that way, and you figure out, oh my gosh, this was the craziest way that I did this. The next time I do it, I am not going to move that thing. I'm going to do it the way Miss Walker said do it. And do you think that I learned how to do stuff just like that? And what works? And you'll hear me say this a lot. This works for me. I need to figure out your way that it works. When you're doing a skill, for instance, doing a sterile dressing change. You know about a sterile dressing change? You know what sterile means? Means I can't contaminate anything. Do you think you're going to contaminate some stuff? Yeah. You can bet your bottom dollar you are. And you know what? It's okay. If you do what? If you fix it before you do what? Touch the picture. Exactly. It's okay You're going to do things over and over. One of the biggest things that, talking about sterile dressing changes, or when you got sterile gloves on, one of the biggest things that I have learned when I put sterile gloves on is I hold my hands like this. Now that doesn't mean that you have to do it. Do you know how many times I've contaminated stuff? 1,000 billion times. But I have learned that when I put that, when I get my sterile field out and everything, and I've got my sterile gloves on, if I do this, this is not normal to stand like this, is it? So if I'm doing something that's not normal, then I'm going to tell my brain's going to say, you know, Lynn, you're standing there for a reason like this, so you better not touch anything that's not sterile. That's just one of the things I do. And the reason why is when you've got those sterile gloves, you got to keep them above your waist. How many people, when they are stand there with their hands up, as soon as you put those gloves on, what do you want to do? Well, you just contaminate them. Okay? So if you stand like this, or stand like this is not normal. And this is like a trial and error. You're going to have many times of trial and error as you develop your skills for nursing. Another thing, and I told you a while ago, is intuition. You gotta go with your gut. How many times have I said that, Shannon? But what do? And you're thinking, okay, I don't have any experience, Ms. Walker. How can I go with my gut? Well, I think there's a little being upstairs in the big city that sort of tells us, oh my gosh, this is what you need to do. It's called experience, too. You don't have the experience. So there's a lot of times you're afraid to go with that gut on. Just like when you took your test yesterday. Or taking any test, and you're reading through it, and then you thought, I know the answer. And then you think, well, no, let me think about this. I think I need to go look at this other answer because it might be right. But what do you think was the answer? First response. What do nurses do when they have a situation and they got to act on it? They got to go. And where do you think they're pulling it from? Their gut. I got to get it in there, and I got to go with it. Now, that's probably a little bit more harder for you to do because you don't want to trust yourself at this point in your progression. You don't want to trust yourself, but I'm telling you, you got to sometimes listen to that gut. The other thing that you got to look at is there's some evidence-based practice. Have you ever heard of evidence-based practice? If you ain't ever heard of it, you're going to hear of it now. Okay? Do you think that we just decided one day as a bunch of nurses running around and said, okay, when my patient's O2 sats drop down to 76, I think I'll put some oxygen on. I think we were just like sitting around saying, okay, let's do that. There was evidence. People did lots and lots of trials, lots of trying to figure this out kind of thing, and said, if a patient's O2 sats drop down to 76, you need to put oxygen there. That is evidence-based practice. Every intervention, everything that you do for your patient, you have to know why you're doing it, and has it been proven that it works. Does that make sense? Y'all are leaving me. Come back to me. Do you see what I'm saying? It's not we just decided that this might work. If a patient has surgery, see if y'all know this. If a patient has surgery, what is one of the biggest complications of having surgery? A, B, C. Pneumonia. That is a complication. Airway. we talked about the other day? Airway? That is one of the biggest complications of surgery. So they have done research out there and says, okay, every patient that has pneumonia is gonna potentially or at risk for pneumonia. So I've got to do something as a nurse to prevent that from happening. With me? There's been research that says that if a patient has surgery, I need to do something to help them not get pneumonia. Give me something I can do. Incentives for auditor.
Turn, cough, deep breathe.
Turn, cough, and deep breathe. Did you think we just made this up? No, there's evidence out there that proves us that if we do these things, we are going to make that patient better. So as you're using your critical thinking skills and learning how to put things together to help safely take care of this patient, you've got to use all of these measures. You got to do trial and error. You got to go with your gut, and you got to have some proof to why you're doing what you're doing. Your book is an excellent resource. Okay? It's going to tell you things that you need to do. Questions? You okay with trial and error? You know what that means? Keep trying until you figure out a way that works for you. Intuition, what's that? Go with your gut. Research methods. I got to have some evidence-based practice. Okay? When you're faced with lots of different things going on as you're caring for this patient, what are you going to do? Y'all have already read. No, you're not going to holler, Miss Walker. You're going to prioritize. You're thinking, oh, Miss Walker, I don't know how to do that. Well, let me tell you, from this day forward, until you take your state board of nursing, until you practice 25 years of nursing, you are going to have to learn how to prioritize. You're going to have to learn. What is one of the biggest things when we prioritize that we look at? A, B, C. I got to look at airway, breathing, and circulation. Let me give you an example. Karen has a big decubiti on her coxsackie. Big old thing. Big. Oozing. Got junk coming out of it. Stinks. All that kind of stuff. Then she has pneumonia. As I'm planning my care for Karen, what is going to be my priority? Pneumonia. My pneumonia, because that's going to affect my airway. Does it matter if her skin's intact? No. If she can't breathe? No. Okay? Not that I'm not going to take care of her behind. I will. But that's not going to be my highest priority, because if she ain't breathing, it don't matter what is happening. Okay? So as we're planning our care, here's your best breathing. Maslow's, I told you the other day, you gotta know it. You got to know this. My best thing for me to make sure that my patient's needs are met is this bottom line, and it's basic life needs. So when you're thinking about doing your care and prioritizing your care, you've got to look to see, is this basic needs of this patient? Basic needs meaning food, drink. Are they breathing? Do they have shelter? Are they warm? Now there's one on here that we always have a big discussion about this. Sex. I mean, it actually says sex there. So sex is a need. And it is very important to meet it. Okay? Now we have this discussion every year. Yeah, turn that off. I don't want my husband to hear that. So I'm going to have to give him more. Because Miss Walker said that sex is a need. It has to be met. And it does. Y'all think I'm picking, but we always have a discussion about this. Is this really talking about the act of sex?
No.
It's talking about, exactly. It's talking about recreating and making babies. You know, I don't think it's saying that. Where I take it is I think sex is important to meet the needs, but I think it's more of continuing. Okay? So we always have a big discussion about that. But do you see where I'm talking about I've got to make sure that my patient's basic needs are met before I worry about if he is going to get that CEO position at Food Line. Okay? Yeah, that do I say that I don't care about your getting that position as a CEO of Food Line? I'm not saying that. I'm saying it is if I'm trying to prioritize my care for my patient, I've got to make sure that these needs are going to be met before I worry about him getting that big promotion. Okay? Does that make sense? You got to know this. If you do this, you will have no problem whatsoever prioritizing. State Board of Nursing is going to give you 4 patients. I'm going to give you 4 patients on a test and say, who are you going to first? And you got to be able to look at all 4 of those patients and say, according to Maslow's, who am I going to go see first? And it's always going to be basic needs and your ABCs. And you pick that. Okay? And it's not that I'm trying to teach to the test. When I go out into a patient's room and I'm going to assume care of that patient, as I'm planning my care for my patient, I'm using Maslow's. Because I'm going to set up a priority list. I'm going to set up a whole list of problems, and we're going to do that in just a little bit. A whole list of stuff that's wrong with my patient. And I got to figure out which one am I going to help fix first. Does that make sense? Is it going to be easy? No. Not when you first start. It's not going to be easy. But I can tell you, please don't use skin before you use breathing. Okay? Don't put skin above everything else. Now, it's not that I don't like skin and I don't take care of my patient, but I can tell you without a shadow of a doubt, I'm never going to worry about somebody's skin if my patient's not breathing. Okay? I'm not going to worry about that one bit. I got to worry about them breathing first. Okay? All right. I think I'm at a point. Questions? I can let you guys go take a break. All right, we finally made it to the nursing process. You've heard so much about this, and you're like, okay, you know, we're finally getting here. So we're finally, what in the heck is the nursing process? The nursing process is, there's 5 different steps to the nursing process. And it is a process that we go through to help us do an assessment, formulate some diagnoses, plan goals for our patient, do interventions, and then we evaluate it. So we'll go through each one of the steps of the nursing process. The reason why we have the nursing process is we have to identify the client's health status. So we have to gather data to help us start formulating all the things that we need to help take care of that patient. the two things that you will see when you're gathering this data and starting the nursing process is you're looking at two different types of needs for your patient. You've got an actual need. Actual means it's going on now. Okay? It means that they're having breathing problems, or they're having airway problems, or they're having circulation problems. Okay? That's an actual problem. Or you can have a potential problem. Now you're going to hear me use these two terms together. I'm going to say high risk or potential. Those two terms mean the same thing. Okay? And what this means is my patient doesn't actually have this problem, but due to the health status of him, he is at risk to develop this problem. Okay? Patient had surgery. We know that airway could possibly be an issue, circulation, but he's going to have to stay in bed for 5 days. What do you think with a system? What system do you think could possibly be jeopardized or could have caused a problem if this patient's got to stay in bed for 5 days? Skin. Now, I told y'all skin's not a high priority, but it is sometimes. I mean, when you're looking at that situation, is it a high priority? I have to look at the situation and say, does my patient have any skin breakdown now? No, he does not. So that is a potential or a high risk because he's going to stay in bed and he could possibly have some issues with skin breakdown. With me? He doesn't actually have that problem, but due to the situation, he's going to possibly have that problem. So, high risk potential is the same term, but it's when I look at prioritizing, I would never put a high risk or potential problem in front of an actual problem. You got me? That is very important. So if you have a bunch of diagnoses, and we'll talk about that in a minute. If you have those and you have to prioritize that, you are not going to put a potential or high risk problem in front of an actual problem that your patient has. Okay? You really need to digest that. Because I'm going to ask you every week when you go to clinical, I'm going to ask you many times, prioritize this list of needs for your patient. And if you've got a potential for skin breakdown, you are not going to put that at a high risk. At an actual problem. Does that mean I'm not going to do anything about that? No. Right. It just means that I've got to address it, but when I'm looking at what do I need to do first, as a nurse, that is not going to be something that's going to be high on my list. I'm going to get to it, but I've got to get other things first before I get to that actual potential problem. Okay, it'll make sense in a little bit when we get on a little bit more. Another reason why we have the nursing plan process is we need to have a plan. Remember I said the other day, you're going to have a plan of care. So you're going to have some map, so to speak, or some plan of what do I need to do to help take care of this patient. I got to have a plan on what I'm gonna do. As I'm planning that, I'm gonna start looking at things I need to do to help me meet that goal. Okay? And as I meet that goal, I'm going to start formulating activities that I need to do to help me meet that goal. And then after I've planned my interventions, I'm going to carry them out, do them, and then I'm going to look and see if they worked. That is a short version of the nursing process. What we're going to do now is we're going to go through every step of the nursing process. Okay? Every step in depth to show you what you need to do to carry this process out. I'm going to go straight into, all this is just stuff we've already talked about. All right, assessment. ADPI up here. And I'm going to keep ADPI up here for the next couple days. Because our first step in the nursing process is assessment. What does the nurse do first? Assess. Always. I've got to assess the situation. How do I do this assessment? You guys did this on SimChart, didn't you? You did this on your physical assessment on your partner, didn't you? Okay? Is that gathering data? Tell me other places I can, or other ways I can get data. Not just a physical assessment. What's other ways I can get data?
Lab.
Get some information from the lab work. Communication with the patient. What kind of things are you going to get when you communicate with him besides his assessment? His history. I need to know what's happened in his life. I'm going to be getting some information now. That is called, when I talk to the patient and gather information, that is called a source, right? A patient is a primary source. Okay, and I think I've got that on one of my things. My patient is my primary source. So if I'm going to communicate, I'm going to get a history from him. Did you get a history from your partner when y'all put it in there? Okay. You're going to do the same thing from the patient. When you get into the clinical setting, one of the good things is there's going to be a history and physical on your patient on the chart or on the computer. So you're going to be able to gather some of his history through the computer. What do you need to do when you get that history? Read it, yeah. Try to understand it, yeah.
Confirm it.
Exactly. What's another day? Good job. How about it? What's another word for confirm? Verify. Validate, exactly. Because that's going to give me away. Yeah, I'm going to look in there and I'm going to see that this patient has a history of COPD, has a history of coronary artery disease, has a history of asthma. So how am I going to evaluate that? Or validate that?
I'm going to ask.
All I'm going to do is go and say, I see that you've had some problems with your blood pressure. Then, as I'm asking that, I can say, oh, are you on any medication? And then I can validate what the meds that I've got. So this is letting me also do what?
Assess the patients.
Assess their mental status or their needs or their
Thinking process.
or their
Cognition.
what do we just go over in class that we need to do with our patients all the time?
Patient safety.
I heard it. They,
They're alert.
Alive.
Keep them
plan of what I need to teach him. Woo! So we can gather all kinds of information through this assessment. And as we gather the information, we're going to be able to plan a lot of things to help this patient meet their needs that they've got wrong. Right? We'll talk about that more. As you can see on this little thing, or maybe not, do I need to turn that on? Are you okay? The first step is I need to collect data. We know how to collect data. We collect data through the primary source, which is our client. What if my patient can't talk? I got to use a secondary source like a family member, wife. Now, one of the things that trial and error I've done is never assume that your patient's person that's with them is their wife or husband. Okay, I've stuck my foot in my mouth more than one time and said, you know, oh, your wife's gonna. You always need to find out when you're in, if there's a bunch of family members in there, before you start asking any questions, you need to ask the patient, if they can talk, who these people are. And it is okay for me to discuss their information in front of them. If the patient can't talk, whoever family member's there, say, can you tell me your relationship to this person? Yes, I am his girlfriend, but don't tell his wife. But you've got to figure out who these people are, because you can't be given information about patients if you don't know who they are. That is breaking HIPAA. So you always need to find out who these people are before you start discussing any information about the patient's history or business. Okay? Don't you dare say what if right now. Because we can go all day long. Well, what if it's his girlfriend and they're find out who this, and that is going to be your secondary source. Some more questions?
Oh, patient can't talk. There's no family member, no contact number. That's a what if, I know, but still.
That is a what if.
Okay.
Patient can't talk. No family there. Nobody around. I've got to do what I can to save that patient. Okay, if he's in a critical situation, I'm going to do my ABCs and care for him. Okay, I cannot turn away from anybody that is dying or whatever. Now, if we're just in the hospital setting and there's no family member there and your patient can't talk, we have to rely on the chart. We have to rely on the nurse that's taking care of him, and we have to rely on the physician to get our data. Okay? So this is a team approach. Okay? Team approach.
If you know their name, but they're not in community, you can look at the system, see if they've ever been in a history chart at the hospital maybe.
Yes, you will get a history out of the computer if they can't talk to us. If they're not able to verbalize and stuff, we always have to check the name in. Okay? To see who they are. Because as soon as they came in and they're in a hospital setting, they have to have an armband on so we'll know who they are.
Mentally handicapped people are really hard to deal with if there's nobody there.
It is. It's very
They
difficult.
fight decisions.
Exactly. So, in that situation, as we're carrying out the nursing process and we start to learn how to do interventions, if you have a mentally handicapped person, you're going to really have to adjust your care for them, aren't you? You're not going to go bring an encyclopedia in there and tell them to read it. Okay? As far as your care. You've got to look at, and that's what I'm glad that you brought that up, because every time you care for a patient, it needs to be individualized to that patient. In other words, if you do your own map of care and you got all this stuff on here and you've got a mentally challenged person and you have 18 things that you're going to teach them, that is not going to be it's not going to be realistic, and it's not going to be an individual care, because that is not going to work for that patient. And we'll talk more about interventions as we get going. All right, in this assessment, we're collecting our data, we're organizing our data. I'll show you how to organize that in just a minute. Validating data, just like we talked about a while ago. Let me just give you an example. What if you have you have a patient come in and you started gathering their data and they got high blood pressure. Okay? Your CNA goes and checks the blood pressure and it is 162 over 102. You going to take her word for it?
No.
What are you doing as a nurse? You are going to validate that. Because, yes, I trust my CNAs. I love my CNAs. But if I've got an issue, for instance, if she took it with a machine, I need to make sure that that's the adequate and right reading in order for me to validate that information. I'm going to get me a blood pressure cuff, and I'm going to take my stethoscope, and I'm going in there and listen to that blood pressure myself. So when I call the physician and I talk to him, I can say, my CNA took it, it was 162 over 102. That was the machine. I went in manually, I took it, I got 164 over 104. So I found the deficit, and I validated to make sure that they were the right thing. Okay? So as an RN, if you find deficits, you've got to validate that information is correct. And during the assessment, you know that you have to document all of your data. So during the assessment, collect data, organize data, validate data, and document data. All right. As we're gathering this, we've talked a lot about how we get it. This is where, when you do your head-to-toe assessment, or let me back up just a minute. When you look on that computer, and it's got a history and physical on there, you can use that history and physical. It's also going to have an RN who's done an assessment on them. You are not to document their assessment. That is their assessment. I need your assessment. Okay? So, and there's a lot of times you want to go in the first day, you look at that computer, and you want to look and see what the nurse documented. So it's going to give you a little bit of an idea. When I go listen to my patient tomorrow, the nurse heard wheezing, so I'm going to get my ears tuned in to be listening to that wheezing. That's okay if you want to do it that way, but I don't want her assessment. I want your assessment, because patients change daily. Minutes. I can go in there, you can go in there and do your assessment. I can come in 15 minutes later, listen to the breath sounds, and I don't hear a thing that you heard 10 minutes earlier. Okay, so I need your assessment. It needs to be systematic, and you always have got to continuously assess your patient. Now, I don't mean go and do a head-to-toe assessment on your patient every time you walk in the door. That is not what I mean. I mean, as soon as you walk in the door, yes, you're going to do that head-to-toe assessment. But if there's abnormalities in there, i.e. breath sounds that were abnormal, I have to constantly be keeping up with the abnormalities. You see what I'm saying? And it'll make sense a little bit more when I tell you what an intervention. You go in, you listen to your patient, they're wheezing. Okay, all through the thing. One of my interventions is to have the patient get a breathing treatment. So I call respiratory. Respiratory comes up, gives them a breathing treatment. What do I need to do at that point after they've had that intervention? I need to go reassess that, don't I? To make sure that what we did worked. Okay? It'll make sense a little bit more. But you are constantly assessing your patient, because they can code, they can crash every time you go in. I always I do my head-to-toe assessment, then I come in as an hour later or whatever, and I'm still assessing them to make sure that Chelsea's breathing okay, her color looks okay. You know, I'm constantly making sure that things are, I'm evaluating or asking her if she's still got pain. So I'm still looking, I'm constantly assessing my patient. We look, you know, we talked about getting the history and the physical. There are also lab values that you can use. I think somebody mentioned that just a little bit ago. Now, when we first go into the hospital setting, we probably will not do labs in the beginning. But you need to start looking at those labs, and you need to start seeing if they're high or low. And you need to be looking to see what has made this patient's lab values abnormal. We're going to do that when we go to the clinical setting. When you're required to look at the lab values, you're going to say, I've got a hemoglobin. Everybody know what hemoglobin is? No, not yet. Maybe. Hemoglobin, it's the little one, the little cell inside your vessel that has the oxygen on top, and it goes like this, and it takes oxygen and dumps it off to the brain, and dumps it off to the liver, and dumps it off everywhere. That's the one that takes oxygen everywhere. Okay? The lab. All right. So I got a hemoglobin. What's the normal range of hemoglobin?
12 to 16.
12 to 16. All right. I don't expect y'all to know that. Okay? I'm just throwing it. You go in and your patient's hemoglobin is 8. Think there's what kind of problem? Circulation problem. Did y'all just critically think?
Yes.
Some of you did. Some of you are not critically thinking with me. My patient, hemoglobin, 12 to 16. Your patient's 8. What does hemoglobin do? Carry oxygen everywhere. It's low. So is everybody getting... Is everybody getting an issue with oxygen? I mean, all the organs getting issues with oxygen? No. So we have a circulatory problem. Did you critically think? That is critically thinking. Did you do it? Are you proud of yourself? Give yourself a high five. All right, good. So anyway, that's what I want to see. That's critically thinking. That is what you're going to start happening. When you start doing that, you're going to say, "Woo! I got it. I finally got it." So anyway, okay. Labs, diagnostic things. All that, you're going to get that from your assessment. Y'all think I'm crazy? Material contributed by other health personnel. What do you think I'm talking about when I'm talking about there? Report, yeah. I got to see what respiratory said about this patient, don't I? Because they got respiratory breathing or breathing problems. Who else? Dietary. Who else? Exactly. The reports that you get from them. Exactly. Who else?
Other hospitals.
I don't know what other hospitals yet. Radiology. CNA. Because isn't this a team approach? We got to work with everybody. I call dietary all the time. I told y'all that. PT. Let me see what they're doing with this patient. Everybody that's having anything to do with this patient, they're going to be charting somewhere, because if it didn't chart it, they didn't do it. Right? So I want to know what PT did, because if I've got a patient who's got some issues that needs PT, don't I think I need to know how the therapy's going to see how they're doing with it and how they're responding? So I've got to use all this information. So this is a pretty big part of nursing process, because you've got to be gathering data from lots and lots of different places. Things that you sometimes often forget is allergies. When you start giving medications, you have got, when you go in to take care of your patient or administer medication, you're going to ask them their name, their birthday, and do you have any allergies? Because you need to know if you're giving them any medication that they're allergic to? What's the most common?
Penicillin.
Y'all are getting good at reading my mind. That is one of the most common things. So let's say you were gathering your data and you saw that your patient's allergic to penicillin. And you look down at his medications and Dr. Jones has written an order for penicillin. Well, Dr. Jones read that order, so I'm just going to go ahead and give it. Why not? The doctor wrote it. I've got to look at, I've got to do what the doctor says.
Gotta be an advocate for the patient.
Right. Say it loud.
You gotta be an advocate for the patient.
Exactly. You got to be an advocate for that patient. What are you going to do when that doctor writes an order for penicillin? You're going to call him and say, Dr. Jones, you idiot. No. Very nicely. Was that therapeutic? No. Not a very good therapeutic. Dr. Jones, I was reviewing my patient's history, and I saw that she's allergic to penicillin. You have ordered penicillin 500 milligrams BID. And I'm he's like, okay, you'll give me a new order. But see, if I went ahead and gave that patient that medicine, I got big trouble going on. Okay? You've got to know their allergies. You've got to know, what did I just do? I couldn't out and didn't even know it. Lord have mercy. That's what's going to start happening to y'all. You're going to start critically thinking, and you're not even going to know it. I want to look and see what kind of histories they've had with surgeries. I want to look and see, one of the biggest things we don't pay attention to when we're gathering data is different types of folk healing medications and stuff. A lot of people, when we're getting that history from them, they don't think that, cinnamon is something that is considered a medication. But it has a lot of effects for people. And I have to make sure exactly what they're on, because what if they're on a medicine that can't be given with cinnamon? Probably not. Just made that up. But, you can't, they don't think of it. A lot of people don't think of fish oil being a medication. Everybody takes fish oil now. And that is different types of things, and they don't think that that's included. So make sure you ask, is there any other over-the-counter medications or any other religious practices that you do? They may do yoga in the corner for 30 minutes, between 8 and 9, or 8:30 and 9:30, they do that. That's part of their, I've got to know that. So as I'm planning my care, that is part of their ritual. I need to know that I need to get things done before that time, because that's what they do. Okay? Very, very important. Any chronic diseases that they have. All right, now, this is, as we're gathering data, there's two different types of data that we need to look at. There is subjective and objective data. Subjective data is what is apparent only to that patient. Only to them. That is a symptom. So in other words, I need to ask that patient to tell me in their own words, why are you here? Tell me why you're here. Well, I got hit by a car. Okay. Or I'm having chest pain. I need to know what they perceive it. What do you think one of the hardest things to get people to evaluate? And really, not really evaluate, but to tell you, for you to understand. A symptom that patients come in and tell you, and you're just not sure how to put your finger on what they're saying. It's a subjective symptom. Pain. Pain is a subjective data. And we'll talk more about that when we get into objective. But that is a symptom. If they're telling me they're nauseated, Can I see knowledge? No. Can I see it? I got. Sometimes it's things I can't really see. Is how they're feeling. What's going on with their body. Now, as far as pain, they can tell me that their head's hurting and it feels like it's about to explode, but they're over here jamming on the, dancing around and stuff. I still have to say he's in a lot of pain because he told me he's in pain. Right? He told me. That was a symptom that he told me that he was hurting really, really bad. So that's his subject. So now we have objective information. So objective means that this is something I can measure. So if my patient come in and said, I got pain, how can I get my hands around what type of pain and how bad is it that can make it objective?
Blood pressure.
Blood pressure, because blood pressure, what happens with pain? Blood pressure goes up.
The breathing, respiration.
The respirations could go up if they're in pain.
Maybe patients,
Heart rate could go up. Guarding. Because that's something I'm actually seeing him do. And I'm seeing him go like this. Facial expressions. Those are things that I'm actually seeing that I can measure. Another way, if a patient's telling me they got a pain or having pain, I say, give me a scale from 1 to 10. 1 being the least amount of pain and 10 being the worst. What number is your pain scale on? Is that something I can measure? They said it was a 10. Something I can measure. What other things can I measure as objective? Besides vital signs. Huh? Lab values, exactly. I can measure those because it tells me that my hemoglobin is between 12 and 16 and his was 8. I can measure that. What'd you say? Oh, who said that over here? I heard it. Oh. Urine output. Can I measure output? When they go pee-pee? Their O2 levels. They're things that I can measure. That's signs and symptoms. Or signs that I'm seeing this patient that I can assess. That I can see with my own little eyes. I can smell with my own little nose. I can measure that. So my patient's telling me subjective information. I'm in pain. My head hurts. That's what he feels. But as a nurse, I've got to get some objective information. Tell me about your pain. On a scale from 1 to 10, tell me what it is. See, I can actually see that. So as I'm gathering that data, I have got to use both subjective and objective data when I'm doing my assessment. Okay? You got to know the difference between those two. We talked about this just a minute ago, sources of our data. Primary is my client. Secondary is any family member, support person, healthcare personnel, records, reports, labs. Those are all excellent secondary sources, but you have to have some validation. In other words, Deanna comes up to me and says, Miss Walker, my patients, I would like to know what my patients' WBCs are. And I'll say, oh, they're 6. And go on. Is she going to trust me? No. She's got to make sure that she goes to that chart and looks to see if that patient's actually, his WBCs is 6. Well, there's 16. Oh, I'm sorry, Dan, I forgot the 1. You got to make sure you're doing this care for this patient, you got to make sure that you validate that data and make sure that it's right.
Is there a reason that we would ask them first, but we have to go and look at their chart anyway? Or can we just skip that process? Because we have to
Just
look at
skip
the chart
that
validate. Okay.
But you'd be surprised at how many students come up and say, Ms. Parker, can you go check this for me? I cannot. I do a lot of things, but I'm not going to check your labs for you. Because, believe it or not, on the prep day, I have already been to the hospital. I have looked at every one of your patients, and I know everything about your patient. I know lab values that are abnormal. I know what diagnostic tests that they have already had and what the results are. I know their history. I know their physical. The only thing I have not done is physically laid my hands on them and done a head-to-toe assessment on them. So if there's anything that we ask you, we already know the answer. 9 times out of 10 in pre-conference. Unless there's been an update in lab values or something like that over the night that when I left. So I'm going to know about your patient. So when I question you on clinical, and there's a reason why I'm questioning you, because something's going to be going on, whether it's abnormal or it's going to help you take care of your patient. Okay? But as far as the nursing process goes, you know how to gather this data. I'm not on here, but I can tell you when you're in the clinical prep situation and you can't find out information you need, please come to me. I will help you. It may just be the fact that you don't know where it is in the chart. Okay? Don't hesitate to go to your instructor and say, I need some help. I know that I got to get this data and I can't find it. Then come to us. We will help you. I should put my name up here. I am part of it. But I am not a part of your assessment data. But I will help you. All right. We talked about patients. And we talked about this in communication a little bit. You're going to have to use support people when you've got pediatric patients. Because they're not going to be able to tell you a lot of the information. If you have a 3-year-old and he's had tubes put in his ears and has asthma, I can't go to him and say, tell me the date that you had your tubes put in your ears. My child had his tubes put in his ears and he's 21 years old. I couldn't tell you the date. Tell you about the time. But I can't expect a 3-year-old, so I'm going to have to use their support people in those situations to help me gather data, because it's going to affect my care of my patient. Alright, I say all that stuff. Y'all can read that. We've talked about that. Whew, have we talked about literature? Do you know what I'm talking about, literature? Evidence-based practice. Exactly. All that stuff. We've talked about how we're going to get all this data. Through your assessment, through interviewing, observing. A lot of this stuff is just pretty neat. All right, gathering data by using your senses. You have to be organized. Notice the data, select data, organize data, interpret data. Always focusing on your client. Now, you can see my teaching methods are not reading the PowerPoints to you. So if I say stuff, these are my notes. So if I get ahead of myself, you just get over it. All right, let me see this. Oh, I'll go through this interviewing thing, then I'll give you another 15. We talked so much about interviewing patients yesterday, and you've already practiced doing your assessment. So I'm not going to go over this again. I do have I did put in there the closed-ending questions because in the chapter of communication it doesn't talk about closed-ending questions and open-ended questions, but we talked about that in communication, didn't we? We did. All right, begins with when. So that's going to be a little bit better for you. Open-ended questions, we talked about that. Tell me what brings you to the hospital. We talked about time and place. Seating, distance, opening, body, closing. Thank you. All right, let me see. I might want to stop right here. Yeah, let me go ahead and just stop right here. And y'all take a 15-minute break. One of the ways that what I use, I'm trying something different this year. I used to have a case study. We went through the case study, but I'm going to do it all on Monday. And then I'm going to give you a case study, and we're going to go through and we're going to look at the assessment. We're going to formulate nursing diagnoses. We're going to go through every step with that particular case study. And then we're going to develop a map or a plan of care. Okay, so I'm going to do it on Monday as opposed to, I usually do like, this is the assessment part, and I think I'm going to do it all together. I think that's going to work. But let me just tell you, one of the biggest ways is you can start organizing your data is I usually put all of my subjective data on, I just get a piece of paper and I list every bit of my subjective. Then I list every bit of my objective data that's wrong with my patient, that there's an abnormality there, okay, that there is a problem there, i.e. subjective data would be I'm in pain, okay. What other kind of subjective data?
I got a headache.
I can't breathe. I got a headache. I'm nauseous. Okay? So all of that, I would list every bit of that subjective. What was that? It's talking to you. Oh, good. It's talking. Then I would get all of my objective data, which would be pain scale, 10, blood pressure, O2 stats, anything that I can measure. That is how I organize my data. Okay, so we've got those two organized. We can start working on formulating a nursing diagnosis. You can also use these different eras, Jordan's, and I got the page number for you, Orum's Self-Care. This Orum's, I really need you to start looking at that and getting that down pat because that board wants to know that. They want to know about Orum's Self-Care, the 8 universal self-care requisites. Roy's is important, but not as much as, you just don't see Roy's a lot anymore. But Maslow's, and I can't tell you, you got to know your Maslow's. You also are going to be required to know the developmental theories. Erickson is the major one that you've got, and you should already through your psych classes have learned about Erickson's. So I'm not teaching Erickson's. All right. Okay, we've already talked about validation. All right, second phase of the nursing process is diagnosis. And that is nursing diagnosis, not medical diagnosis. There is a difference. The second stage is as we have included or gathered, validated, organized, clustered all this data together, I am now going to have to formulate a nursing diagnosis for my client, so of the problems that they have. Okay? So, through my diagnosis, I'm going to analyze my data. I've got my subjective here. I've got my objective here. One of the ways that I just do it is as I'm looking at each item that's under my subjective, I look and see, is there a problem with airway? If there's an I always start my ABCs. If there is a problem with airway, then I put an airway there. Then I look and put breathing beside each one of my objective and subjective issues. Okay? So if I look and see there's a lot of airway problems, then I know that I've got to focus. One of my high priority nursing diagnosis has got to be an airway issue. Okay? If I see lots of things that are wrong with my client, I'm going to identify their health problems, their risks, and then I'm going to formulate a nursing diagnosis. Now, you're saying, what in the heck is a nursing diagnosis? And how do I figure out which nursing diagnosis I need to use? That is very hard to start off with, but let me show you the parts of the nursing diagnosis. You're going to have 3 different parts of a nursing diagnosis. You're going to have the statement. You will have the diagnostic label. Actually, there's 4 parts. Excuse me. You have the etiology. Does everybody know what etiology is? It is the cause. Etiology is cause. And you're going to have, which I didn't put it there. Did I miss something? You should have the defining characteristics. Middle. Oh, and I got it on. It's coming. All right. I like my other description better. Let's go on it. All right, let me go back a minute. I know I'm confusing y'all. I am confusing myself. Right this moment, I'm confused. Okay? That's when you use another source and you get all these different things. Anyway, now, let me just tell you nursing diagnosis. Nursing diagnosis has to be NANDA approved. Okay? When I say NANDA, it is just an organization that got together and said, we need to speak some nursing lingo. Okay? If you have a nurse that works in North Carolina, if you have a nurse that works in California, no matter where you work, nursing diagnosis is our language. So if you speak to a physician about a nursing diagnosis, he's not going to know what in the heck you're talking about. This is all about us in our lingo. In other words, if Deanna, I know I use you a lot, sorry. If Deanna is taking care of a patient and she tells me that her patient has an ineffective airway clearance, I'm going to know exactly the things I need to be doing for a patient who I don't know anything about her, but I know I will have some type of knowledge about how I need to take care of that patient who has an ineffective airway clearance. Okay? So in other words, if she says she needs to run down and get a bite to eat, she can look at me and say, I've got Mr. Jones, he's in room, this is 68, he's got an ineffective airway clearance. I've got Mr. Albert in whatever room, he's got this nursing diagnosis, and she can tell me exactly what's going on she doesn't have to give me a long report. She can tell me the nursing diagnosis, and I can already start knowing what needs to be done for that patient. Okay? So this is our lingo. I'm going to show you in just a little bit where you're going to find your lingo, or how you're going to figure out what you need to do. There are two types of nursing diagnosis, and we've already talked about that: an actual problem and a potential problem. Okay? You heard me, I put risk. Means the same thing as potential. Alrighty? We talked about that. Alright, here. Does anybody have their, can you pull up MedSearch? Good.
I don't think that was on, because we all have those in the bundle.
Alright, so you're going to take my word for it. Right? You can't-
We'll validate.
can you pull up
We're gonna
MedSearch?
validate.
Okay. Yeah, y'all can validate when you go look at it.
Okay.
Since everybody doesn't have that resource, let me tell you how you're going to figure out where to find a nursing diagnosis to start off with. Because you're thinking, okay, I've gathered all this data through my assessment. Now I've got to formulate a nursing diagnosis. Okay? You have the diagnosis, medical diagnosis, pneumonia. Where are you going to go find your information about pneumonia?
Table.
In your Tabors or in your MedSurg book, right? And you have to do all that pathophysiology and the etiology and the diagnostic test and the teaching and all that kind of stuff, right? Right after all that information, there is going to be a section in your MedSurg book that says nursing process. Right after that disease process. Nursing process. And guess what? It's going to have number 1, assessment. And it is going to have a whole list of information there that you should or could possibly assess with a patient who has pneumonia. Okay? It's in your book, trust me. MedSurg. You got pneumonia, you got pathophysiology, you have a nursing process, and it says assessment. So that is going to be a whole list of stuff that you could possibly see in a patient who has pneumonia. Number 2, what do you think is going to be there? It's going to have a list of nursing diagnoses that could possibly be a good nursing diagnosis for a patient who has pneumonia. My goodness, that's sort of simple, isn't it? Right. So here's verification, validation. Here it is. Ineffective airway clearance. And then it goes through assess respiratory status, assess, monitor arterial blood gases, place in bowel position, assist to call, provide fluids. A whole list of stuff that's telling you what you need to do as far as assess. And then right underneath it, I just scrolled all the way down, sorry. It's going to say, these nursing diagnoses might work for this patient. Now, what do you have to do? Because how is this plan supposed to be? Supposed to be individualized, isn't it? So are all those nursing diagnoses going to work for your patient?
No.
No. You're going to have to figure out how to know which nursing diagnosis is the best ones for your patient. Okay? I'm going to tell you that it's going to be very simple. It seems not so simple right this moment. Okay? So when you find, and it's going to have crazy words like ineffective airway clearance or impaired skin integrity. Okay? That is the actual diagnostic label that you're going to, it's going to be a negative thing, because negative means that there is a problem or an issue with your patient, that we got to figure out what is going on. Okay? That's the first part of the nursing diagnosis. And once we get through this, I'm going to write on the board what a nursing diagnosis looks like. Okay?
Will we always know the medical diagnosis first before we put on the nursing diagnosis?
Actually, good question. When you go to the hospital, you will get a medical diagnosis of your client. This is a starting point for you. That medical diagnosis, then looking at the pathophysiology, will give you some ideas of what nursing diagnoses you need to pick. Later on, next semester, when you can start formulating nursing diagnoses on your own without needing a resource. But right now, you will always have a medical diagnosis to go on to help you start formulating your nursing diagnosis at this stage. All right? You will always have that resource for you. Okay? All right, so the diagnostic label is something crazy. Then it has ineffective airway clearance. Now, if y'all pulled up, who's got tables? Okay. Do you see ineffective airway clearance? Okay. Y'all see that? All right. Then it's going to say related factors or risk factors. What does etiology mean? Cause. It is the cause. Are you going to make this information up? No, you are not. You are going to see it in your book, and you're going to look and see what part of that etiology is the reason why my patient has this diagnosis. Give me some examples. All right, so my patient smoked for 52 years. So can I put ineffective airway clearance related to smoking? Can I do that? Because it's right there in the book.
Yeah.
All right. What else does it say there? Well, he smoked, so he didn't have no second answer. What did you just say?
COPD.
COPD. What is that?
Diagnosis.
Medical diagnosis. Can you use etiology
No.
as a medical diagnosis? No, you cannot. Because this is a nursing diagnosis, not a medical diagnosis. So what other things does it say there? It does say physiological, and that's where the COPD and asthma, but we're not using that. So what's actually happening with this patient? He's got pneumonia. He's got excessive mucus, right? He's got exudate in the alveoli. So you're going to get the related to's or the etiology straight out of the book, according to the cause that your patient had. Okay, y'all are lost, aren't you?
You're not going to put all of it, you just put one that's related.
Exactly. But this is where you're going to get the information too. Every one of those are not going as the risk factors. Okay? They're not. That's why we've got an individual plan of care. Okay? It's individualized. So I'm going to look and see. In other words, if you've got a patient who's got ineffective airway clearance and you put related to smoking and he's never smoked a cigarette a day in his life, that is not going to be a correct etiology. Okay? Not going to be. You've got to have a risk factor. So it's the cause of why this is happening.
Ineffective airway clearance related to smoking as evidenced by exudate and excessive.
No, not evidence by yet. Yeah, we ain't got evidence by it yet. Okay? So, alright, let me just tell you. I think this is the thing. Because I'm getting lost spaces and I can't stand that. Yes. Huh? You want the deer? Who's got the deer? Who needs the deer up? Okay. All right, so we have a nursing diagnosis of ineffective airway clearance. We're going to do more of these, okay? Ineffective airway clearance. This is the diagnostic label, because there's 3 parts of the nursing diagnosis, okay? This one's the first part, the diagnostic label. Ineffective airway clearance. Related to is the cause, right? Or the etiology. Alright? So tell me what you found under your TABRs under ineffective airway clearance is my related to. What is it? Smoking? What was the other one? Except increased amount of mucus. Oh. I can't spell. Exudate in alveoli. So the reason why my patient, or why I chose a nursing diagnosis of ineffective airway clearance, was because my patient smoked for 52 years. He had lots of mucus in his chest, and he had exudate in his alveoli. Now,
But you're not always going to pick all 3 of those.
no, you may not. You may just have one related to factors. Okay?
Depends on the patient.
Exactly. Depends on the patient. So, I've got to have some proof. Because, you know, it's all about proving that I have a good nursing diagnosis for my patient. So, the third part of this is as evidence by. That is the third part of it, which is also, which is called the defining characteristics or signs and symptoms. So the third part is called defining characteristics or signs and symptoms. When I was doing my assessment, I gathered data. What type of data? subjective and objective data, right? Was that evidence?
Yes.
So where do you, was that subjective is symptoms,
Their symptoms are.
objective is signs. So what do you think's going right here? The signs and symptoms that my patient exhibited through my assessment. So all these problems that he had is what made me formulate this nursing diagnosis for my patient. Does that make sense?
So you
All right.
include excess mucus and all that.
Now I'm going to show you what goes here. Is that what you're asking me? Okay. So what evidence did I assess on my patient?
History of smoking.
All right. Signs and symptoms.
Shortness of breath, coughing.
Let's say he coughed. Say increased coughing.
Shortness of breath.
Shortness of breath. What other things do you see with somebody who has increased amount of mucus? Let's go back to cough. What do you think?
Productive.
I heard it. It's non-productive. Exactly. Non-productive cough because he's got pneumonia, doesn't he? And he's got increased amount of mucus, and he's got a bunch of junk in his alveoli. So that means he's not able to get it up, is he? Is that good or bad? That's bad. So non-productive cough. Not good. Shortness of breath. What do you think his respirations are going to be? Increased respirations. Give me a number.
24.
24?
30.
Oh, dang. Let's make him sick. 34, excuse me. 34. All right, what other thing do you think is going on with him?
Heart rate increase.
Increased heart rate. What do you want his heart rate to be?
130.
130?
150.
Y'all making him sick.
He's tachycardic. He needs to be up on swim.
All right, what other things you think is going on? I heard somebody say something about O2 sat.
Increased FTSAT.
Decrease, what do you want his O2 sat to be?
85.
36. Somebody start CPR. All right, what else you want wrong with him?
Would you have wheezing and coughing or?
Woo! He's got wheezing.
Could he have pallor, be real pale because of the...
Right. Okay, wait a minute. Where is my wheezing at?
In the right lower lobe.
Bilateral lobe.
What's wrong? Oh, that's talking about. Okay. And where's it at?
Bilateral.
Right lower lobe. Wonderful. All right. Where at? What else did y'all say was wrong? Good. Or let's make him even sicker.
Capillary.
On lips. Oh God! Capillary refill. What do you think it'd be?
Greater than 5.
You want it to be 5?
Yeah.
What are you doing here?
Critically thinking.
Critical thinking.
I'm so excited. So, what are you also doing here? Giving you what?
Diagnosis.
You're giving you a lot of evidence to prove what?
Diagnosis.
That this is a good diagnosis. Because the more of these you have means the patient's got a lot of problems, don't they? And that's validating that this is a good nursing diagnosis. Now, prioritizing is hard to do, isn't it? So if you've got 3 nursing diagnoses there, and you've got one that's got 8, and one that's got 4, and one that's got 2, is there gonna be a problem for you to prioritize?
No.
Because the more problems they have under there, the more validation you have, and it's got to be a higher priority because there's so many things wrong there. So it's gotta be right up there up front. Okay? Gotta be. All right, let me say one more thing, we'll do another one. What if I have a high risk nursing diagnosis? I would definitely go here. Right. So let's say I have potential impaired skin integrity. What goes next? Related to. So who's got Tabor's? Look up impaired skin integrity. Got it? No. What do you think one of the major reasons?
Better.
Will bed rest go do that? That'll work there, won't it?
Wheelchair bound.
Or wheelchair bound.
Brown.
Paralysis. You want to be paralyzed too? Make them sick. So you see the related to's, the reason why he's could possibly. Does he have skin breakdown yet?
No.
Because if he had skin breakdown, it wouldn't be potential. Exactly. So we got potential for breaking down this skin. And this is the reason why. Where's my as evidence by?
There's no evidence.
There's nothing there.
It hasn't had nothing there yet.
I am so proud! Right, because if it's a potential or a high risk, there's no evidence there to prove. Because if I've got evidence, it's a actual. Oh my word, it hasn't ever went that smooth. Got it? Actual problem? You got evidence. What'd you say?
So you don't know who you're teaching.
I got the cream of the crop. That's what I got. Woohoo! Alright. We've got evidence over here, a lot of it, right? But there's never going to be any evidence here if it's a high risk or potential.
If he's on bed rest, wouldn't Botox be a potential and high risk?
Exactly. Okay, can you find a nursing diagnosis that might go along with a blood clot?
Decreased circulation.
Because we can't use medical diagnoses, can we? No, because the DVT is a medical diagnosis, right? So now I've got to find a nursing diagnosis that may be having an issue with a blood clot. All right, do you want it to be actual or do you want it to be potential?
Actual.
I'm not liking these things.
But actual.
If it's the, you tell me you want to do an actual one first? Okay, so let's find a medical diagnosis. We got to find a med. Do you want to do DVTs? You want to do that? Okay, who's got their med search book?
How about ineffective tissue?
Is it tissue with the DVT?
Circulation.
Who's got a med-surg? Can y'all look at med-surg?
I ain't been able to find anything you said in there.
It was in there, I promise.
What was it under? For the
It was in the annex part of it. The very, very back of it. Very, very back of it. All right, let me see if it's got. Okay, what are we doing? Are we doing DVT? Yeah. All right, DVT. All right, who's got something that can look up deep vein thrombosis? Who's got a sock? Preferably your med-surg book if you can staff right it. Can you staff right